Today we will discuss about the clinical evaluation of anemia, and in a case of anemia we have to know about its the severity, type and the cause for the anemia, and a good history taking is needed for understanding about the severity, type and cause of the anemia. And about the symptoms, usually in anemia they present with excessive tiredness, mostly non-specific symptoms or excessive tiredness and dyspnea on exertion, palpitation, dizziness and headache. Headache is due to the decreased oxygenation of the tissues, and in most people anemia may goes undetected due to vague symptoms, and most commonly people with mild to moderate anemia report a feeling of weakness or fatigue, general malaise and sometimes poor concentration, and people with more severe anemia often presents with dyspnea on exertion. And very severe anemia prompts the body to compensate by increasing cardiac output, leading to palpitations and sweating and later to heart failure. And next, about the detailed history taking. In age children, we have to suspect the worm infestation, and if it is elderly, we have to consider the risk factors like malignancy or GI blood loss, pernicious anemia, and in sex, in female, there is more chance for the anemia due to the physiological conditions, increased physiological requirements, pregnancy, lactation, and we have to suspect menorrhagia, polymenorrhea, and then occupation. Occupation, if it is farmer or field worker. Farmer, then hookworm infestation is a possibility. Then we have to suspect for iron deficiency anemia. And next, dietary history. And history of, we have to ask for history of pica, that is clay, dirt or sand, ice and all, and inadequate intake of green leafy vegetables, and pure vegetarian or not. Then about the alcoholism. So if there is history of pica, then we have to suspect iron deficiency anemia, and if decreased intake of green leafy vegetable, then we have to suspect iron deficiency anemia, and if it is pure vegetarian, we can suspect vitamin B12 deficiency, and also in alcoholism also we can suspect vitamin B12 deficiency, megaloblastic anemia. Then GI symptoms, if there is any GI symptoms like worms in stool and pruritus ani, melena, altered bowel habits, weight loss, chronic abdominal pain like peptic ulcer, NSAID use, bleeding PR, like hemorrhoids, And frequent frequency of, if frequent stools are there, then suspect giardiasis, amoebiasis, topical sprue. And if there is worm infestation suspecting, then we have to suspect iron deficiency anemia. And also the malabsorption, chronic malabsorption in case of giardiasis, amoebiasis, sprue and all. And the bleeding PR, myelina and all, there we can suspect iron deficiency anemia, chronic blood loss. Next, about the drug history. The anticonvulsants use like phenytoin, phenobarbital, valproic acid. In that we have to suspect megaloblastic anemia. So what are the drugs which can cause or which have tendency to cause megaloblastic anemia? Phenytoin, valproate, phenobarbital, then metformin, methotrexate, that cause folic acid deficiency, 5-fluorouracil, hydroxyurea, acyclovir, then ranitidine H2 blockers, because they can cause intrinsic factor secretion problem. Next, about the past history. Past history, any history of surgery like gastrectomy, ileal resection, and recurrent episodes of jaundice or hematuria can suggest hemolytic anemia, and recurrent leg ulcers, priapism, bone pain, that can suggest the sickle cell anemia. And about the medical history, like a history of hypertension, chronic renal failure, HIV, malaria, thyroid disease, liver disease and all. They can mostly cause iron deficiency anemia, also megaloblastic anemia also. Then family history, consanguineous marriage or not, because of for suspecting hemolytic anemia, and if there is any family history of anemia.